Okay, so now we're at question number 61, continuing on from the last video. So here we're looking at a GIT question now. So this is another little thing that NBME does like questioning a lot about GIT anatomy in general. Anatomy of both things, where all the organs are, as you can see in this picture, what's retroperitoneal, what's not, and then of course the anatomy of blood vessels, all the different blood vessels and where they supply stuff, especially branches of the celiac. Those are pretty significant. So here in this question we're seeing a 28-year-old man comes to the emergency department because of a 6-hour history of cramping and severe left mid-abdominal pain. He had a single episode of vomiting. Temperature is fine. Abdominal exam shows a mass in the mid-abdomen. A CT scan of the abdomen with contrast is shown. Right, so they gave this entire image, both the top one and the bottom one. The abnormality is indicated by the arrow. Intussusception of which of the following portions of the intestinal tract is the most likely cause of the patient's pain. Now, they were nice to you. They actually told you it's intussusception, which a lot of people wouldn't really necessarily catch because it's like, you could see the target lesion, but at the same time, it's not the most obvious target lesion. It's not very, very evident, but he just has intussusception. Now, depending on, like your anatomy knowledge, this is a relatively easy question because they're pointing in this side, right, on the left side. They even tell you this is the left side. And intussusception occurs in the small intestine. So the left side, you can see from here, the left side has both things, right? So that's your jejunum up there, but then this is, there's also going to be ileum there too. So it was definitely a weird kind of question, but good thing is they don't have both things as an answer choice, right? You're not going to get intussusception of the duodenum over there, right? So it was a pretty safe bet to just pick jejunum. Stomach, cecum, and appendix don't get intussusception, so it's pretty, it would be pretty unreal to really pick any of those other answer choices. In this image I inserted here just to show you, you can see the duodenum is mostly on the right side, right, on the right side of the stomach. So if it's on the left side, it was probably the jejunum. This question, an Rh negative woman, G3P2, has had an increasing bilirubin concentration in amniotic fluid obtained between 22 and 29 weeks gestation. Umbilical cord blood obtained at 29 weeks gestation had a hematocrit of 6.2%. Transfusion of which of the following types of packed red cells to the fetus in utero should be used to correct the anemia? So they just told you it's an Rh negative woman, right? And then there's all these A, B, and C and all that. Well, not C, but A, B, and O are all there in your answer choices. So how do you work through this? Well, the mother is Rh negative, so she's going to generate Rh antibodies. Okay, the fetus affected by anti-Rh or the Rh antibodies, the fetus will be affected by it if it is Rh positive. Even if O Rh positive is given, then the mother's Rh antibodies will attack transfused blood. Therefore, giving O Rh negative is best. So the concept of picking whether A, AB, B, or O just came from the obvious idea that O negative is the universal donor. Right? So just giving O negative is the best thing you can do, and that was answer choice G. Right? O negative is a universal donor. Type O blood already doesn't really have any kinds of antigen on it to begin with, and then when you make it Rh negative, it also loses the Rh antigen on it. Right? If you gave Rh positive blood, then obviously if the mother makes Rh antibodies, she's going to kill that blood. Right? So this was in effect a very easy question, really just testing you on the basic understanding of what antigens are present on each type of blood. And that's not really a difficult topic, right? If you have type A blood, then you have type A antigens. So, if someone has antibodies against type A blood, they'll kill it, right? You can give type A blood only to a type A patient. Same thing goes for type B. You can only give type B blood to a type B patient. And then, of course, type O, you can't give them anything besides type O because a type O patient, since their own blood doesn't have any antigen, they make antibodies against both type A and type B blood, right? Whereas an AB patient, right, you can give them either type. You can give them type A blood, you can give them type B blood, or you can give them AB blood, of course, right? But you cannot give AB blood to anyone else at all. You can't give this blood to anyone else because everyone has antibodies either against the A part, the B part, or both. All right. So this is a pretty straightforward question. Nothing crazy or confusing here. Just asking you how to save the baby. That's it. 35-year-old woman has weakness and fever. When she was 25 years old, she was treated for Hodgkin disease with mechlorethamine, oncovin, procarbazine, and prednisone. And when you look at all those medications, you're probably like, what the fuck are the first few? You just know prednisone. She has had a splenectomy. There is no evidence of lymphadenopathy. Peripheral blood smear shows numerous blast forms. Which of the following is the most likely explanation for these findings? Okay, so, when you see numerous blast forms, right, that's what they tell you. The peripheral smear is diagnostic for, all of these answer choices, basically, right? To pick one, you just need to look at the peripheral smear. If the peripheral smear is showing you numerous blast forms, it's most likely AML, acute myelocytic leukemia, right? It can't really be the other ones. Let's take a look at that stuff real quick to revise it. Let's see. Okay, so ALL has many lymphoblasts, right? That's lymphoblastic leukemia. There's a lot of lymphoblasts here. Also, this occurs in kids, right? It's adolescent little leukemics. So that's not going to be our patient. CLL is crushed little lymphocytes. They didn't mention that, right? AML has many circulating myeloblasts on peripheral smear, many different ones too. And then if that becomes CML, you're going to have maturing and mature granulocytes, and you're supposed to look for a low LAP, because a high LAP would be a sign of a leukemoid reaction, which means that the patient is actually trying to fight disease. But if LAP is low, and they have a bunch of blasts, that's a sign of cancer. You're making a bunch of blasts for no reason. Right? Our patient has AML. There really isn't much else to confuse yourself with here on this page. And in your answer choices, they kind of put all of them. So CLL is crushed little leukemics. ALL is adolescent little leukemics. And our patient doesn't have anything for us to pick A or C. The answer would not be lymphoma or recurrence of Hodgkin disease, because those two things would not present with numerous blast forms. All right. Alkylating agents like mechlorethamine, which you probably did not know, increase the risk of AML. Alkylating agents can also cause aplastic anemia. Additionally, AML is the only answer choice that has multiple blast forms like myeloblasts, promyelocytes, etc., etc. ALL is characterized by a single blast form, lymphoblasts. Right? So many ways to find the correct answer, many ways. It all just depends on what you know. If you did know what mechlorethamine is, then that also helps, okay? Because this is an alkylating agent. Obviously, some of these had to be, weird immunology medications, because these were medications that were used for the Hodgkin disease treatment, right? Which means that you would be using some of those cancer drugs that are discussed at the end from chemotaxman, right? From here onwards. So these cancer drugs, you have to remember that not many of them really help with Hodgkin disease. Hodgkin disease, which is the simultaneous type, not simultaneous, contiguous type, right? All in one area and whatnot, not all over the place. It's kind of hard to treat that with antimetabolites or topoisomerase inhibitors or even microtubule inhibitors. They can help, but they won't be the most effective way, right? But when you start using alkylating agents, which are discussed right here, these guys are pretty strong. They're very strong. They cross-link DNA and they just stop it entirely. Right? They stop the replication entirely. So it's very helpful for Hodgkin disease. Here you can see procarbazine, right? Hodgkin lymphoma. So that's kind of similar to the mechlorethamine. They have procarbazine here too. See, another alkylating agent. So those drugs are discussed here, but not the first one. All right, so you could find the answer really just by knowing the peripheral smear, which is something you have to master when you're studying hemonc of the cancers and stuff, mostly the oncology part. This question was, alright, this was okay. So during an experiment, a 22-year-old man receives an infusion of histamine in his left brachial artery. Which of the following sets of microcirculatory changes will most likely occur in his left arm? Right? It's basically just asking you what's going to happen with histamine being given. So histamine is, when you think of histamine, you think of like because of allergy or something, right? And it causes vasodilation. So you vasodilate, always remember that means that blood will be in the vessels, right? Blood, remember, we talked about this a lot when I was doing cardiovascular. I kept mentioning something about using a water hose to check that out. But the main concept is that when you vasodilate, blood stays in the vessel because your vessel now has much more volume to it, right? Much more space in there. When you vasoconstrict, you squeeze, it's like squeezing a water hose. You make the water go faster out of the tube. There's no space inside the tube anymore when you vasoconstrict, so now blood goes to the organs, all right? And that's one of the many mechanisms of how you get end organ damage on hypertension. Here, though, we're going to vasodilate, so that's going to keep blood in the vessels. With vasodilation, resistance decreases, right? So arteriolar resistance is going to decrease, so everything from A to D is wrong. You just knock out half the answer choices just by remembering histamine is a dilator. And more blood is going to stay in the vessels, so the hydrostatic pressure would be higher, right? Capillary hydrostatic pressure is going to increase. So now you're just between E or F. Capillary filtration rate is this very similar concept to glomerular filtration rate, where if you have more blood staying in the glomerulus, then you get more GFR. So similarly here, capillary filtration rate would also increase. So it's just F. Right? That was the only one that kind of threw people off, capillary filtration rate. But when you see capillary filtration rate, you should really compare that to GFR, glomerular filtration rate. And glomerular filtration rate is a capillary filtration rate. Your glomeruli are filled with blood vessels. Right? So when you do something like constricting the efferent arteriole, you stop blood from exiting the glomerulus, so more blood stays in the glomerulus and you have more filtration. Same kind of concept. All right. Here, 25-year-old woman comes to the physician because of easy bruising and bleeding from her gums over the past 2 days. She has been otherwise healthy, excuse me, and has never had abnormal bleeding. Lab studies show, okay, so hemoglobin, hematocrit, leukocyte, platelet, PT, PTT. All right. So her hemoglobin, it's on the lower end of stuff. PTT is 30. All right. So which of the following is the most likely cause of these findings? All right. So she has easy bruising and bleeding from her gums, and it's a female. At this point, you're really between one of two answer choices. It's either going to be ITP or von Willebrand disease. All right. As far as step 1 is concerned, questions like this one are usually, without the labs being given, questions like this where a woman is presenting with easy bruising and bleeding from gums and whatnot, it's a von Willebrand disease. On step 1, a similar presentation with deeper bleeding is usually hemophilia, and the patient's going to be a male. Okay. So here, you can cancel out DIC. If it was DIC, PT and PTT would be significantly higher. Hypersplenism doesn't really make sense because physical exam, they haven't really mentioned hepatosplenomegaly or anything like that, or splenomegaly. Nor have they mentioned, something where you're having like the spleen kind of destroying everything. Because then, there would be schistocytes or something like that. In fact, even this patient might have schistocytes. They didn't really give you peripheral smear, right? It's really NBME type of question to not give you much, but giving you labs was really good. That platelet count of 6,000 is not that high. That's not that good. All right, so looking at a slightly lower platelet count than what you would want, platelets, you do need a lot of platelets, and it doesn't look like her platelets are working that well. You can easily just go ahead and pick ITP and just move on. The hallmark of ITP is isolated thrombocytopenia, right? And that's exactly what the labs gave you. Nothing else is wrong besides the fact that the platelets are a little low. Splenic macrophages kill platelets due to anti-GP2B3A antibodies. This can be idiopathic or due to any kind of weird thing, autoimmune, viral, malignancy, or drugs. So ITP is almost always the answer. If you have it in your answer choices, you really have to consider, is it ITP? Okay. DIC is unlikely because PT-PTT is normal. Hypersplenism would cause anemia. She doesn't really have anemia. Vitamin C deficiency, as a choice E, would not really cause thrombocytopenia. That would be more so scurvy or something. Von Willebrand disease, remember that's a mixed platelet and coagulation disorder, so that would cause deep joint bleeding instead of just mucosal membrane bleeding. It is inherited, and you will see symptoms earlier, not necessarily at age 25. So, between those two, it was easier to just pick C, immune thrombocytopenic purpura. A very high yield answer choice, often the correct answer, and it can just occur for no reason whatsoever. So a question might not really give you a reason, right? When things can occur idiopathically, step 1 really likes that, because then they can just give you a patient where everything is fine with them, and yet they have some kind of problem. because it just occurred idiopathically, and you have to consider that based off of the labs being given, based off of the presentation of the patient, and that's really all we had for this question: presentation and labs. Okay, so 11-year-old boy has had pain in his right mid-thigh for 2 weeks. This is another high-yield topic of NBME. They like testing you on anatomy as if you just came out of med school, and they really like testing you on musculoskeletal cancers. Physical exam shows an area of warmth and tenderness around an ill-defined mass. X-ray of the femur shows a solitary mid-diaphyseal osteolytic lesion with permeative margins, and osteolytic lesions are usually a sign of cancer. The lesion is surrounded by concentric layers of reactive bone, which is the lamellated, or you could call it onion skin type bone, which is this right here. Tissue obtained from the biopsy is composed of poorly differentiated sheets of small, uniform, hyperchromatic cells with a very high nuclear to cytoplasmic ratio, scant stroma, and no visible matrix. So that's the malignant Ewing sarcoma, homerite rosette stuff that they're talking about, small blue cells. Which of the following is the most likely diagnosis? Well, it's an 11-year-old boy with a cancer of the bone. Ewing sarcoma is, one of your easiest answer choices to really pick there. Okay, and they gave you everything for you to be able to diagnose that. So let's take a look at that real quick in the book and review it just a little bit. Right, so first things first, you need to remember that of malignant tumors in the bone, right, there's a bunch of benign ones, and all the benign ones tend to be osteo, and they also tend to be chondro-related. They're mostly, cartilage related, not actual bone. They're very cartilage related. The only ones that are malignant is osteosarcoma, right? Because sarcoma, remember from pathology, sarcoma is malignant. Chondrosarcoma, which is again a sarcoma, so that's malignant. And Ewing sarcoma, again, because all sarcomas are malignant, right? None of these are sarcomas. These are all different, just oma, nothing else. So sarcomas are all malignant. Now, osteosarcoma occurs, in males that are under age 20, and there's usually something else there, right? Usually secondary to some other thing like Paget disease, a major bone infarction, radiation, familial retinoblastoma, or Li-Fraumeni syndrome. Our patient really didn't have a history of anything else, okay? And then in osteosarcoma, you get this osteocod. Right? Remember, think of the osteocod. So you get this Codman triangle, which is a sun-like flaring of the bone, and they didn't describe that in our patient at all. Also, you would note pleomorphic osteoid-producing cells, right? Because osteosarcoma is basically like an osteoblast sarcoma, right? Remember, here we have an osteoblastoma. That's benign, right? And you have an osteoclast one, osteoclastoma. This one's also pretty high yield, giant cell tumor. You get the soap bubble appearance thing. They give you that pretty often, right? Image C. So of the benign ones, I would say osteochondroma and osteoclastoma are the most common tested, high yield. Osteosarcoma, our patient doesn't fit the clinical presentation for that. Ewing sarcoma occurs in younger boys, right? Boys under age 15. And you see these things, the lamellations, the small blue cells, which they gave you, and it is a translocation between 1122 with EWS and FLI1. Okay, so onion skin periosteo reaction in bone is very important to watch out for. Right, this one in the middle, chondrosarcoma, is a tumor malignancy of chondrocytes, and it was tested, right? So enchondroma is the same on histology but affects the hands and feet and are cyst-like. Chondromas are the same as enchondroma and are benign. Right, but chondrosarcoma, this one is malignant, and this is going to be in the medulla of the pelvis, which is a pretty unique spot. You don't really get many bone tumors there. Right, so chondrosarcoma. But again, NBME loves testing on various bone tumors, so you should definitely make sure you know them, and there really aren't that many. Right, just look at many images, make sure you explore some histological images. I did this when I made my musculoskeletal videos, right? Talked about all kinds of x-rays. It's nice to train yourself to be able to see certain kinds of bone tumors and then understand what they are, just based off of how the x-ray looks or how the histology looks or whatever the presentation is, okay? And then make sure for step 1 purposes that you're able to differentiate between a bone tumor and bone metastasis, right? Osteoblastic lesions in the bone are due to prostate cancer, small cell lung cancer, and Hodgkin lymphoma. So this is very high yield. Ural made a graph like this to kind of tell you about that. Whereas there are many osteolytic bone metastases, but it's not from these high yield topics. These 3 high yield topics are very important to remember. Right, so if a patient is presenting with difficulty urinating and has osteoblastic bone lesions, definitely for like 99.9% sure it's prostate cancer. All right, so that's the tiny revision of that stuff. Okay, this was a pretty easy question too. 35-year-old man with bronchial asthma starts taking albuterol, right? And that's the correct treatment for that. Which of the following changes in second messenger levels is most likely in the cells affected by this treatment, right? So what does albuterol basically do? And albuterol increases cyclic AMP. That's it. There's really nothing else to think about that. Albuterol is going to cause bronchodilation. It's going to help you with that. Beta 2 receptors are coupled to GS proteins which activate adenylyl cyclase and increase cyclic AMP. Cyclic AMP then increases the activity of pKa, which phosphorylates myosin light chain kinase, ultimately resulting in smooth muscle relaxation. Albuterol, a beta 2 agonist, is therefore useful in treating bronchospasm. Cyclic GMP also causes relaxation, but it is related to NO and works with MLCP, and it's also mostly related to blood vessels, not exactly bronchodilation. Okay, so very important to make sure you can make those distinctions. Definitely want to make sure you spend a lot of time, before your test on this page right here, right, page 238 with all the receptors, because not only do you need to memorize all the receptors and what they do, right, that's a very big part of pharmacology, but you need to memorize this bottom part here, right? Can I have one M&M? To remember that because this is a question mark, this is GQ, right? The C in can reminds you of phospholipase C, right? And the rest of them you already know, like HAV is for HAV over here, and M&M, M1 and M3, right? The first and third one. That's it. Everything is 1 though. H1, alpha 1, V1. Very easy to remember that once you have that stuff down. Then the rest of them are right here. All your beta receptors, right? And then the H2 and V2 and D1, all of these guys are GS. The only inhibitors are 2 MAD. They're so mad they inhibit everybody else, right? M2, alpha 2, D2. So it takes a little bit of time, but you can definitely memorize that by heart without even having to. After a while, you can talk about it without even having to look at the book. Okay, so 68 here. A 57-year-old woman comes to the physician 2 weeks after finding a lump in her left breast on self-exam. Physical exam shows a 2-centimeter mass in the upper inner quadrant of the left breast. Carcinoma is suspected. X-rays show multiple lesions in the vertebral column, and metastatic disease is suspected. Which of the following veins draining the breast provides the most direct pathway for malignant cells to travel to the vertebral column? So that's the other one that oh, it wasn't here. Let me bone. Let me see. We just did the bone one, right? I just want to show you that graph again. 510. Okay. So breast cancer, you want to make sure you remember, can cause either type. Okay, osteoblastic or osteolytic. So there is no solid thing for that. Just make sure you understand that part. So in our patient with what did they say she has? She has multiple lesions. They didn't even describe what type, right? They didn't say osteoblastic or lytic, but she has vertebral metastasis. So now, which of the following veins draining the breast provides the most direct pathway for malignant cells to travel to the vertebral column? Right? A very, very silly anatomy question, I guess, but totally doable, right? So axillary vein, cephalic vein, intercostal veins, internal thoracic or the mammary vein, and late thoracic. A lot of people wanted to pick internal thoracic, right? Because it is the mammary vein. But here the correct answer was C. Your intercostal veins, right? Your intercostal veins, which you're seeing right here, go straight to your azygos, and that is where you're trying to go. The others over here, they're all a little more lateral. Okay, very lateral. We wanted something that was very medial because your vertebral column is very medial. And the most medial vein, the only veins going medially, going towards the medial direction, are your intercostal veins, right? Your intercostal veins are under your ribs, and they're all draining blood medially, right? And that's exactly what we're seeing here. So under each rib, we have veins coming medially to the azygos vein, which will then allow blood to be, able to metastasize the cancer into the vertebra. Right? The other answer choices were, I had an image for the internal thoracic part too, but I don't know where it is. Let me see. Intercostal. We need images for the internal thoracic. Let's see. Yeah, this was a good picture too, right here. Okay. So here in this picture, you're kind of looking at the breast, and you're looking at the patient from above or below. I'm not sure entirely. Below. We're looking at the patient from below. So you can see your internal thoracic one right here, the mammary one. It's also kind of medial, but it's very anterior. It doesn't really drain all the way to the vertebra, right? Whereas you can see your intercostal stuff is going to come all along and go straight to the vertebral area, which is exactly where the azygos vein is. So it was kind of unfair of them to put the internal thoracic answer there, because obviously a lot of people are going to be very inclined to pick that since, mammary, but that wasn't the correct answer. So you want to make sure you're thinking very logically about, metastasis. Make sure that the blood is actually traveling towards wherever the metastasis is being sent. Okay, 10-year-old boy receives a renal transplant from a living related donor for cystic renal dysplasia. 3 months later, there is tenderness at the site of the graft, and serum creatinine concentration increases from 1 to 2, so things are not working. Which of the following findings on renal biopsy is most likely to confirm a diagnosis of rejection? Right, and then you get all these answer choices. But you have to remember, it really helps to know what the answer is before looking at the answer choices, or have an idea of the answer, right? This patient got the transplant, and now it's been 3 months, right? So it's been a while. So it's not acute. It's not hyperacute. It's slightly acute, but not very acute. But either way, you need to remember what causes all of those, right? So let's take a look at the revision stuff at the bottom. So hyperacute, which would occur almost immediately, has preformed antibodies, right? And that's going to form complement activation. So that would be the correct answer for that, and we don't have to worry about that. Acute is weeks to months, right? Before becoming, like 6 to 7 months later, that would be a chronic level. So at that time now, within weeks to months, the reason it took weeks to months is because you had to make T cells, you had to make lymphocytes. And the only answer choice where they mention lymphocytes is E, and that's the correct answer. You're going to see that the graft antigen is activating host CD4 and CD8 T cells, leading to parenchymal cell damage, interstitial lymphocytic infiltration, and endotheliitis. All right, very important to be able to catch that. Chronic stuff is a type 4 hypersensitivity. It's also going to just have a bunch of T cells, lymphocytes. And at this time now, with chronic stuff, you note arteriosclerosis and mononuclear infiltration. Right? Whereas graft versus host disease, which is also type 4, is the other way around. It's the graft that's attacking the host, right? Because the host is usually immunocompromised, and the graft is just going to have a bunch of antibodies. Right? So that's really it. The graft isn't necessarily alive, but it came with antibodies. Okay, yeah, this is just a memorization question. I like that they picked on C8 of all things, because this picture from USMLE RX and the lecture from USMLE RX where they used this picture almost 3-4 years ago was actually pretty nice. They did a good job explaining how all these dermatomes kind of turn. That's what the red arrow they made here is all about. And everything kind of twists around. So they tell you an 18-year-old man, there's actually a bunch of extra information in this question. 18-year-old man comes to the physician 10 days after injuring his right hand during a game of tag football. He says that he was attempting to tag an opposing player when he inadvertently caught the tip of his ring finger on the other player's jersey. He felt a popping sensation at the tip of his finger and then immediately felt sharp pain localized to the finger. He noticed swelling of the finger. Several minutes later, examination of the right hand shows mild tenderness over the palmar tip of the ring finger. He is unable to flex the distal interphalangeal joint of the right ring finger, but he is able to flex the metacarpophalangeal and proximal interphalangeal joints. This patient most likely injured a tendon whose muscle is supplied by fibers from which of the following nerve roots? Okay. Now, on the right side, I'm showing you the dermatomal stuff, as well as, it kind of goes slightly hand in hand. So there are 8 cervical nerve roots, but 7 cervical vertebrae. C8 comes out below the C7 vertebra, whereas the other cervical nerve roots come out above their respective vertebrae. C4 is for scapular elevation, C5 for shoulder abduction, C5-6 for bicep reflex, and C7, C8 for triceps reflex. You gotta just spend time memorizing that shit, right? It's kind of really extra information for the most part. But you know that if you look at the brachial plexus, let's go back and find that real quick. Musculoskeletal. Hold on. Oh yeah, right here. Alright, so if you look at your brachial plexus, we're looking at things that are happening in this area, the blue area, right? That starts from C8 and T1. That's it. Right, so that's kind of how you get this answer correct. It is C8. Let me put this image here too. Right, so so the picture on the right is more so just for like the dermatomal stuff per se. Our question isn't exactly about dermatomes, but I did want to discuss it because you get similar questions where they mention dermatomes, okay? But our patient's thing is more so about the brachial plexus and nerve roots, right? So following which nerve root, the only one that goes to the hand, I really like this color-coded version of the brachial plexus. So the only thing that goes to the hand, which is the ulnar and median, and our thing is ring finger, so that's more ulnar, that's C8. Okay, that's why this is all blue over here. Right, whereas with the wrist, which is usually like carpal tunnel syndrome, median nerve, that's going to be C7, right, the green stuff. Okay, so not the worst thing at all. I mean, another correct answer would be T1 also. This one also uses the same stuff, right? So same kind of concept again. 35-year-old man comes to physician because of a 6-week history of pain in his right arm and tingling sensation in the right fingers of his right hand. In the fingers of his right hand. Physical exam shows weakness of extension and pronation of the right forearm. The tricep muscle stretch reflex is decreased. Which of the following nervous structures is most likely involved? Right, so same thing again, back to back, which is why it's always so good to like really study the topics that are high yield on NBME. If you're trying to specifically pass NBME, it really helps. All right. So here the correct answer was C7 nerve root. Why? Because this guy is having issues with things that are related to the radial nerve. Okay, right? Extension is all radial nerve, and for radial nerve stuff, right? Triceps muscle reflex is decreased. That's radial nerve. Can't do triceps is a extension muscle, so you can see the extension stuff, which is going to be C7 right here. It goes straight to radial. That's it. It's really just a memorization thing. There's no actual thinking involved per se. Okay. Then here I just wrote some memorization tools that you can utilize if you wish. This was an okay question. This wasn't actually that bad at all. I think it was pretty obvious when you read the question. Antiphospholipid syndrome is very straightforward. It's always about spontaneous abortion, the key word. And they have that here. So 27-year-old woman comes to the physician because of swelling in her left arm that began 10 days after a spontaneous abortion in the middle of her second trimester. A radio contrast study shows axillary vein thrombosis. Bleeding time is normal, PT is increased, PTT is increased, and thrombin time is okay. Which of the following is the most likely cause of this woman's condition? Well, she has spontaneous abortion and thrombosis. Both of those must be due to the same thing because antiphospholipid syndrome actually causes abortion due to the anticoagulant activity, right? And that anticoagulant activity, is also causing her to have weird thrombosis, and there's really no other reason to pick any other answer choice. So the patient would have some antibodies. The anti-beta-2 glycoprotein inactivates protein C and S and antithrombin 3, leading to hypercoagulability, causing recurrent abortions. So you can treat this with warfarin. The fact that PT is also elevated through some people. Oh, that's the wrong through. Excuse me. Through some people off. As antiphospholipid syndrome has an increase in PTT according to FA, but PT can also be high. because protein C and S are gone, so you now have too much of factors 5 and 7 activity. Right? Remember, protein C and S cut and stop all the coagulation factors. Dysfibrinogenemia is a coagulation disorder caused by a variety of structural abnormalities in the fibrinogen molecule that results in abnormal fibrinogen function. Remember that fibrinogen is related to platelets, so bleeding time would not be normal. Fibrinogen was the one related to GP2B3A and helps with aggregation of multiple platelets. Antithrombin deficiency, choice B, has no effect on PT or PTT or TT. Okay, antithrombin deficiency is basically going to be a patient who gets heparin and it doesn't work, right? Because heparin uses antithrombin, so heparin will be ineffective in those patients. And that's really all there is to this question. So it wasn't so bad. They did try to confuse you a little, but you know, once you know the diagnosis, you should just pick it. Don't worry about it too much. She's not going to have two different reasons for her spontaneous abortion and thrombosis. 73. The risk for hemorrhagic stroke from drug X is investigated by utilizing a questionnaire about drug use in 702 patients with hemorrhagic stroke and in 1376 control subjects contacted by random digit dialing. Which of the following best describes this study design? Okay, so you don't ever want to overcomplicate what's happening. They gave you a design where there are cases and then there are controls, so just pick the case control study and move on. That's really all this was, right? They have patients and they have controls. Case control asks what happened, and that's what they're trying to find out, right? And it measures the odds ratio of a subject. In comparison, cross-sectional would be what is happening and would assess prevalence by enrolling subjects regardless of disease, right? That's a very important thing, regardless of disease. So you can't really pick cross-sectional survey. A lot of people fell for cross-sectional because, you know, the investigation is happening right now. But the investigation is not about things that are happening right now. Right? Investigation is about things that have happened. Right? Patients with hemorrhagic stroke, they already had the stroke. Right? Whereas in cross-sectional, it's you do everything regardless of disease. You don't break it up for disease versus not disease. Okay. And cohort is for relative risk based on exposure. Okay. And this isn't a type of design where you have any kind of exposure. So it's very important to be able to actually have like good mastery of those biostatistics, not only the equation, but also the conceptual aspect of what each thing means and what they test for, right? What is being checked with each study design, because you know they tell you like cross-sectional would measure prevalence, right? So you look for frequency of disease and frequency of risk-related factors in the present, right? Can show risk factor association with disease, but does not establish causality. What is happening? You don't really enroll patients based off of disease here. In case control study, though, you do enroll people based off of disease, and it checks the odds ratio of getting that disease. Cohort study, right? That one enrolls people based off of exposure, and it checks the relative risk that exposure carries, right? And you have to know that mastery of these three things very well. And then there's a bunch of other things that you have to figure out also, obviously, but that little basic period right there, you really want to make sure you have a good understanding of. And doing practice questions is always going to be very critical. NBME loves asking questions about biostatistics stuff, so you definitely want to make sure you spend enough time mastering biostatistics before your NBME. Memorizing equations is one thing, but you know, conceptual things like this where there's no use of equations is a different thing. This is a cool question because they actually use this picture very frequently. I think this is the 4th time they've used this picture for a completely different type of question too. All those questions were not similar, but they were all based off of this picture. So that just goes to kind of tell you that the picture, at least in this case, wasn't that significant because they give you a lot of information. So they said a 4-year-old boy is brought to the physician by his parents excuse me, because he had 2 bacterial urinary tract infections during the past year. Physical exam shows no abnormalities. Radiologic studies of the urinary tract show marked dilation of the left ureter and renal pelvis, which is exactly what the gross image is showing you too, and minimal left-sided renal function. A left nephrectomy is performed. A photograph of the resected specimen is shown. Microscopic examination of the renal parenchyma is most likely to show which of the following. So you're looking at choices and you're trying to figure out, what would you see? So this guy had recurrent UTIs. So the renal parenchyma being dilated is also just going to be inflamed. Right? That's like the good way to think about it. The other answer choices just don't make any sense, so you would just go with B. He's obviously not going to have amyloidosis. That's something you see with older people. Membranous glomerulonephritis, nephroblastomatosis. First of all, I'm not even sure what D is. And this wasn't renal cell carcinoma. Renal cell carcinoma is related to the renal vein. And, there's no mention of anything like that here. So you're kind of just between B and C. And if you don't remember what membranous glomerulonephritis is, then you probably haven't finished studying renal path that well, because the first thing you have to master is nephritic versus nephrotic syndrome. And our patient doesn't really have issues of either one of those things. They don't have nephritic or nephrotic syndrome. They have dilated stuff, right? Dilated stuff, which basically means that there's some kind of hydronephrosis here, which is why you wouldn't pick membranous nephropathy. But membranous nephropathy, right? This is the one with what do you call it? The antibodies to phospholipase A2. Okay, this stuff, and it's often related to HBV, HCV, lupus, solid tumors, some kind of drugs, all kinds of weird stuff. None of which was really our patient's concern. Okay, so there's really no reason for you to pick C here either. Oh, and I put it here. This is the same picture used in NBME 20 and 21, with one of them being a 66-year-old with urothelial cell carcinoma, and the other being tubular atrophy, and another being Wilms tumor. Right, so all kinds of issues. A lot of people pick D here too because they recognize the same picture, but it was not the same question. Right, so be very careful. All right, here's a urea cycle question. So now this is pretty rare on NBME. They don't really test you much on biochemistry or metabolism biochemistry. Not all of biochemistry, just metabolism in general. They don't test you on metabolism that much. But here they're asking you, which of the following is required for the synthesis of glucosamine from fructose 6-phosphate? Right? And if you don't remember any of it, then you really wouldn't know. You would pretty much be guessing at that point. But here the answer was glutamine. Why would you know this? Okay, so this picture up here is your urea cycle. Okay, and you're kind of just, you don't really see glucosamine in it. But down here, there's another pathway, right, called the hexosamine pathway. And you probably didn't know, but when you look at this, right, you've all studied this already. The glycolysis stuff, glucose 6-phosphate, fructose 6-phosphate, a bunch of intermediate steps that first aid thinks you don't need to know about, and then all of it eventually comes down to just breaking down the glucose. This is the intermediate steps that they don't tell you in first aid. Right, so let's take a look at it real quick. Biochemistry, metabolism. So let's see. Yeah, right here, right? So we all know these steps in here, right? There's a bunch of stuff. All of these steps, these are the ones you kind of get to see. From glucose to glucose 6-phosphate, glucose 6-phosphate to fructose 6-phosphate, then to fructose 1,6-bisphosphate, and then G3P and DHAP, right? That's everything right here. There's actually a lot more to that. After fructose 6-phosphate, you can see, right, you're going to make, you see this N-acetylglucosamine, right? Glucosamine, there's a bunch of glucosamine stuff, and then acetylgalactosamine, right? So all of that stuff that's happening here, those are the things this question was about. It's kind of a pretty irrelevant question, to be honest. Not really something I wouldn't think you would see that on your step one, but this is just a question about hexosamine, right? The hexosamine pathway, and that requires glutamate. You can see glutamate, or glutamine. You can see glutamine up here, right? Which does require glutamate. You put glutamate in as glutamine, it converts back to glutamate, but you get the glucosamine in between. Right? Glucosamine from fructose 6-phosphate. So this is the exact step they're talking to you about, and you need a glutamine to do it. I don't know why NBME is kind of testing you on that, or why you would know that. I'm not sure if anyone learned that in med school, but even if you did, you probably wouldn't remember that anyway. So it's a pretty fucked up question. I wouldn't worry about it too much. Right? But, it doesn't hurt to remember that, just in case it does show up on your NBME or step one. And I got that question wrong too. Remember, I always tell you, if I do these tests while I'm making the corrections too, but I don't do them like a real test, nor do I do it timed. But I do tell you guys when I got a question wrong and I got this one wrong. I didn't know what to put. I had no idea what the hexosamine pathway is. But I didn't want to put arginine or carbonyl phosphate or an acetylglutamate. Those are all urea cycle stuff. Right? So I figured it wasn't going to be any of them. And then I actually just went with ATP. I'm not sure why. Right? But I didn't feel like glutamine was related either, because glutamine is more so related to hyperammonemia. Right? If you remember this stuff in hyperammonemia, everything gets converted to glutamine. Right? So our patient, I don't think of glutamine as an answer choice for anything else besides hyperammonemia, where you run out of alpha-ketoglutarate because you combine it with ammonia, and you run out of glutamate because you also combine that with ammonia, and you get symptoms of not having those two guys. Okay, but yeah, so I didn't pick glutamine. I didn't pick any of them besides ATP. This was just a typical PCOS patient, 25-year-old woman, comes to the physician because of a 6-month history of irregular menstrual periods and progressive acne. Menses have occurred at irregular 25 to 42 day intervals. She's 5'7" and overweight. BMI is 35. Voice is deep. Physical exam shows dark hair over the upper lip and chin, and open and closed comedones over the face, chest, and back. Serum studies are most likely to show which of the following in this patient. So they gave you a pretty good clinical picture of someone who has PCOS. So now, what would you see in a patient with PCOS? Well, patients with PCOS usually seem to be pretty diabetic looking. Okay, so fasting insulin would be high, and at that point you knocked out D, E, and F. Half your answer choices are gone. You can also tell from the clinical scenario of a deep voice and having a mustache and all that hirsutism stuff that their testosterone levels are usually more than normal for a woman. So now you're just between A or B, okay? And then luteinizing hormone, LH. Well, having LH, is an okay thing, but it doesn't really work out for them, okay? And the issue with them, you have to remember, LH is luteinizing hormone. That's okay to have, but what you really need is FSH, right? Follicle stimulating hormone. They have low FSH, which the question didn't ask you about. And it's because of their low FSH that their follicles don't exactly mature correctly, and they end up having cysts, right? And that's why she has irregular menses too. But LH is there, so that's the answer there for A, right? Everything is increased. All three of these things are increased. FSH is low. It's really important to know PCOS. Also keep in mind that not all PCOS patients are overweight. You can have PCOS patients who are very much fit, but they're still going to have some level of hirsutism or male pattern baldness, or super extra aggressiveness or acne because of all the testosterone in their body. So this is PCOS right here. So you can see the hirsutism, the ultrasound showing you all the different cysts. Okay, very important to know. High LH to FSH ratio, which means that LH is high, FSH is low. Right, and it's a very difficult thing to live with, because the repeated anovulatory cycles are scary. You never know when they're going to stop ovulating, and fertility is a big issue for them. Right, so getting pregnant is a major scare for them. Right, common cause of decreased fertility in women. Down here, I do have some extra notes. If you want to check it out, you can always feel free to come back to the video and pause it later. Right, so you have your progestin challenge test that UWorld teaches about, a bunch of extra descriptions from AMBOSS, and then treatment stuff right here, right? So clomiphene, they also talk about treatment stuff, but they don't really go deep into how they all work. Not all of this is treatment for just one thing. Like the finasteride is a way to manage having, the hirsutism. Finasteride is a DHT reducer, lowers the amount of DHT you have. Flutamide also would help with the hirsutism. Spironolactone is anti-androgenic, so that would also be helpful there. Clomiphene is an estrogen receptor modulator, SERM. So, there's a bunch of ways to help these patients, and you can get all kinds of questions on it. Gotta be ready for that. 77, a 56-year-old woman is brought to the emergency department by her husband because she has had headache, confusion, and difficulty speaking and walking for the past 2 days. Mental status shows confusion and memory loss. Her temperature is 102, so that's pretty high. Brzezinski and Kernick signs, which I personally had not heard of before, are absent. Analysis of CSF shows a high opening pressure, protein and glucose, so protein is pretty low. EEG shows abnormalities in the right temporal lobe and periodic lateralized epileptiform discharges. Okay, so she's got some level of seizures. Which of the following is the most likely diagnosis? So my concern here was that they didn't really give a clear answer for, basically A or B. Okay, if it's aseptic meningitis, that means it's viral meningitis. So in viral meningitis, protein would be high. Protein is not high. Bacterial encephalitis, bacteria eat up all your glucose, so your glucose would be very low. But here, the glucose isn't necessarily that low. 40 is okay. So I couldn't pick between A or B at all. And then neurosarcoidosis. Sarcoidosis is very unlikely. Like, sarcoidosis can be anywhere, but seemed very unlikely to me. Tuberculous meningitis would be the phase of tuberculosis where it's kind of going everywhere. You get POTS disease and all kinds of stuff. It's disseminated. I wasn't too inclined to pick that here either. So, considering her age and remembering that HSV is the most common cause of encephalitis, I just went with herpes encephalitis, and it worked out. Although there are no specific herpes indicators, a CSF panel with mostly leukocytes, right, mostly lymphocytes 208, indicates a viral infection, as well as the normal glucose. So you can rule out TB, neurosarcoidosis, and bacterial. Brzezinski and Kernick signs are related to meningitis, but even if you didn't know what those are, the question says there is an abnormality in the temporal lobe, right? Meninges. Encephalitis would be the best answer, especially because herpes encephalitis affects the temporal lobe. HSV1 is the most common cause of sporadic encephalitis. And I remembered that from Sketchy Micro, as well as pretty much every question I've ever done on HSV1. So that's why I was very inclined to pick herpes encephalitis. Okay, which is viral, but if you have an acute viral infection and there's a bunch of viral copies in your CSF, that's when protein gets elevated, right? That's where you would pick aseptic meningitis, which would be one of your polio things, one of those guys, the viruses that are listed on that page. But that's not the most high yield stuff. So what I'm talking about, let's see. Okay, right here. So HSV1, number one cause of sporadic encephalitis, right? Most commonly latent in the trigeminal ganglia, and then it just reactivates. Okay, so that's what happened with our patient. She wasn't that old, but that's kind of what happened to her. The other guys that cause aseptic meningitis are these guys, right? The enteroviruses. There you go, right? Enteroviruses. There's no added sugar because sugar would not be high or low. No organisms because it's virus, and the source of protein would be slightly higher, right? And this is aseptic meningitis. There wouldn't be any sepsis. Sepsis is more so bacterial. So enteroviruses, where are they? What is this? These are the pico. Yeah, these are all your little pico babies, picornaviruses. Not enteroviruses? They are enteroviruses, though. Yeah, enteroviruses are a subsection of picornaviruses, right? Enteroviruses are the number one cause of aseptic meningitis. But our patient didn't really have any reason for us to pick one of those. Protein was not that high. 78. This is a pretty common question. NBME has been recycling this question over and over with different presentations and different answer choices too. But they're always about libido versus nocturnal erections. This was really interesting. So, 66-year-old man comes to a physician because of a 2-month history of the inability to maintain an erection. He also has had fatigue and difficulty sleeping and concentrating during this period. 3 months ago, he had a cerebral infarction with right hemiparesis that has gradually resolved. Physical exam shows no abnormalities. Which of the following additional pairs of findings in this patient is most likely on history taking? So would his libido be normal, and would his nocturnal erections be normal? Okay, and it's very interesting. The only random information they gave you that could possibly help was the 3 months ago having a cerebral infarction. Okay, how do you tackle this stuff? So I picked C. I didn't think his libido would be normal anymore. Libido you know, so let's look at the explanation. When you're thinking of libido, don't just equate it to testosterone. Make sure you're always considering depression. Depression following a stroke is pretty common. I know because I know people who've had a stroke, patients who've had a stroke, and one family member who's had a stroke. Depression is very common after having a stroke, especially with residual physical disability. So this would decrease his libido. Also remember that many people after stroke can also have, issues with tasting things, smelling things. And if you can't taste or smell things nicely, that's pretty depressing too. Nocturnal erections equate to, does it actually work? Right? Not just the vasculature, but also the neural input as well. For example, during a prostatectomy, damage to the pelvic plexus can lead to impotence. There's nothing to suggest that he has vascular or neurologic erectile dysfunction here, which is why his nocturnal erections are going to be intact. And this is one very special kind of case. Depression is always going to give you special cases where libido is decreased, but nocturnal erections are normal. That's literally just depression. Right? You don't have the urge to have sex, but you're fully capable of it. Choice B, with normal libido and decreased nocturnal erection, that would be someone under 60 usually with some kind of injury to pelvic nerves, right? Something has messed up his nocturnal erections only. The physical apparatus is damaged. Choice D, with decreased libido and nocturnal erections, that would be someone with a prolactinoma or someone some kind of medication side effect, or someone who has depression and pelvic nerve injury, messing up both things individually. It's some kind of fusion of things. Very difficult to find someone who has both things. And then erectile dysfunction, right? So organic erectile dysfunction has normal libido and decreased nocturnal erections because you have erectile dysfunction. There's dysfunction of the actual apparatus. If you have psychogenic erectile dysfunction, that's usually related to depression or too many fights with your spouse, stuff like that. In those patients, right, you're going to have decreased libido but normal nocturnal erections. You're unable to really get in the mood because you're always, mad at the person, but they will have nocturnal erections, right? So very important to be able to understand how to figure out if someone's libido is affected and whether or not nocturnal erections are affected. Big differentiating factor. 79. Oh yeah. Okay. So this wasn't so bad at all. Just a question about the lifespan of a red blood cell, and they got very creative with it. 52-year-old man is brought to the emergency department 1 hour after he was found next to a faulty space heater. He's confused. Physical exam shows reddish tinged skin, so you immediately know it's carbon monoxide poisoning. ABG analysis on room air shows PO2 within the reference range and carboxyhemoglobin concentration of 40%. He is intubated and mechanically ventilated with supplemental oxygen. Assuming no further carbon monoxide exposure, which of the following is the best estimate for the time it will take for the removal of all the CO-carrying erythrocytes from the patient's circulation? 4 months. That's it, right? It takes about 3 months for your red blood cells to die. 120 days is the lifespan of a red blood cell. So they didn't put 3 months as an ass choice, but 4 months was the next closest thing, right? Definitely not 1 day, definitely not 2 weeks. 1 month. Like, there's really no reason to pick any other answer choice. You just had to know how long a red blood cell lives. That's all this question was about. And then again, biostats, they love this stuff on NBME, and this one is related to questions. So a randomized control trial is conducted to assess the effect of diuretic therapy on the risk of cerebral infarction in patients with systolic hypertension. A total of 4736 patients with systolic blood pressure measurements greater than 140 and diastolic blood pressure measurements ranging from 50 to 85 are randomly assigned to receive diuretic therapy or placebo. After 5 years, results show the following. And I put this here to make sure that you always want to have your numbers in this pattern, right? Therapy and infarction, yes, yes. Placebo, which is no therapy, and no infarction, no, right? So it is in the standard form. Which of the following best represents the absolute risk reduction for cerebral infarction in patients receiving diuretic therapy? So absolute risk reduction, remember, you don't really want to just memorize the equation alone. You also want to know what it means conceptually. ARR is the reduction in risk due to the intervention compared to the control. So how do you find that? Well, it's going to be C divided by C plus D, right, using this stuff. Right? So 194 over 194 plus 2177. right? And of course they picked really absurd numbers that you can't just add in your head. Okay, but if you know 194 is going to be in your numerator, you can cancel out C and D, and then 194 plus 2177 is going to be more than 2177. So you are between B or F, right? That's it, B or F. Divided by the same thing on the other side, A over A plus B. It's really, sorry, subtracted from. So it's really just C over C plus D and A over A plus B. You're just taking the difference between therapies, right? The top is therapy, the bottom is no therapy. The difference, what did that difference do? Absolute risk reduction. How much did the risk go down because of therapy? Right, so you don't want to truly just memorize the equation. You want to spend some time actually getting what's happening, right? How is that equation coming to be? Put your chart into normal standard format, then work with the numbers in the right way. So it's this column subtracted from that column. That's really all it is, ARR. Once you can memorize these things like that, you don't have to worry about memorizing the equation or making a cheat sheet. But you should be making a cheat sheet, memorizing equations while you're studying, so that by the time you sit down for the test, you have it down. You won't even need your cheat sheet anymore because you probably rewrote it so many times, right? And if you're new to the channel, if you haven't joined enough streams yet, the cheat sheet is something that I introduced earlier in my full FA playlist, where we made a two-sided piece of paper with equations and everything you would need to know that you can memorize and jot down as soon as you sit down for your test, right? That's what the purpose of the cheat sheet was. Because on your test day, you get 2 double-sided blank papers that you can write anything on before starting your test or during or throughout your test. So, writing down all the equations every day just once, it takes about 10 minutes, not even. I'm highly over-exaggerating it. But if you just spend 10 minutes every day writing down all the equations and everything else that's on your cheat sheet, you end up memorizing it by the time you sit down for your test. And that's easy effort that you definitely want to put in. Right? So you just look at, here the answer was just B. You just remember the equation, plug everything in, and you see it. You don't even need to solve it. You don't need to solve it, which is why they're throwing in absurd numbers. It does, looking at this number alone is pretty intimidating. And then they distributed it all over this table, which also makes it intimidating. And that's just how the game works. They're just trying to intimidate you so that you fuck up. All right. But definitely spend enough time, coming up with a good visual understanding of how the equations look. How the equations look. Not just how they look on paper, but where you pick the numbers from on this table. Okay. So that's it for that. Oh, and as an extra, number needed to treat would just be the reciprocal, 1 divided by ARR. Okay, that's another thing NBME likes picking on, NNT, and number needed to harm, NNH. Right, so I'm going to stop here. That was 20 questions. In the next video, we'll go on from numbers 81 to 100. Thank you very much for joining. See you guys again soon.